And today we are in the bits and bytes portion. So we're really getting into the how and the what. This is more technical, less sociological. And we're happy to have you here. Thank you so much. If you want to ask questions, it's good, I think, to start with why, who, how, what, when. Those seem to work well. Next slide. Why, Myhin? Why are we here? You need a neutral data steward if you are sharing the most personal and critical information about people with other people. So not sure if, Facebook is a neutral data steward. Not sure if all of the places that we allow access to our data and our personal information are neutral data stewards, but you can bet that Myhin and health information exchanges in general are to act as a neutral data steward, to protect and act and to collaborate towards the goals of health information exchange, towards reduced inefficiencies, towards improved healthcare access, lower costs, better quality of care and outcomes, and more personalized medicine. Who are you? What do you need? What is your body made of? Next, that's our why. Next slide, please. So this is a who. Who do we do this for? Who do we route and normalize and unify and send and receive information from and to? Lots of actors. Actually, the federal government, the state government, health department, health payers, health systems, PIHPs. Moving down to hospitals, clinics, practices, you can see. And then most importantly, what about the people, the human beings that need information to make better decisions about the people that they know, that are trusting them to take care of them? Doctors, nurses, clinicians, care managers, social workers, hopefully, soon dentists, pharmacists, and also the human beings themselves. What information about yourself is out there and what is needed. We do this at scale, okay? We say at scale, and to me that means we do this in such enormous volumes that I think maybe it just doesn't stick. So I'm going to put the big numbers up here. We have 44,582 care providers that have established active care relationships and are working within and through Myhin in the state of Michigan. Those 44,000 work at the 5,637 care entities that are connected to our network, to your network. Myhin is your hin. And most importantly, 13.1 million unique patient records. So this is probably just about equal to maybe a little bit more for other reasons that we can get into, as the population of the state of Michigan. Next slide, please. We're talking about the who here. We talked about the who last time, but I think it's important for everyone here to understand. We have 147 hospitals in Michigan sending ADTs to Myhin, 663 outpatient sites of care, 295 SNFs today. We're looking to our partner in Point Click Care to get the rest of the SNFs in the state connected. And today, this is interesting to me, currently 76 home health agencies sending ADTs. Very, very interesting. I love to hear how that's working for everybody. Next slide, please. How? This is sort of my how, right? How does it all work? Or why should it work like this? Look, if every single entity, every single office, every single organization had to connect and maintain the pipes to connect to every other entity, organization, sector, that would be a lot of pipes, and it would be a lot of work, and it would be duplicative, and it would not be governed by a nonprofit entity that is not the state of Michigan only, not just hospitals, not just healthcare payers. A health information exchange takes all of these lines, all of these power lines, and makes a really smooth grid for everyone to be able to connect once to get the information they need from everybody else. Next slide, please. Next slide, please. Oh, yeah. Now we're at the best part. I am going to turn this over to Mike Taylor. He is a product marketing manager for MyHin. He has been here for 10 years, so he started working here when he was 12. And I said last time, and I'll say it again, health information exchanges, they've been around for like 15 years, 13 years, Mike, 14 years. I feel like you being here for 10 means that you're a dinosaur and a relic, but also a gem. And so thanks for taking the pressure and moving on with this. If anybody needs me, like I said, I'm going to put my name in the chat. I consistently interrupt. It's a personality flaw. Mike, I'm sorry. And just you guys now have to raise your hands, even though I would say you could interrupt, but now you can't anymore because we're using this thing. Thank you so much for coming. Mike Taylor, over to you.
Awesome. Thanks, Joanne. It's definitely a point in your career when somebody calls you a dinosaur, I guess. That's where I'm at. All right, so today we're going to be going through just a real quick refresher on ADTs in case you weren't here last week. But then we're going to differentiate some of the major HL7 standards from each other so that when you're in conversation with other people, you can really understand documents versus messages versus other things. Then we're going to start our deep dive into ADTs. We're going to take a look at how ADTs are structured. We're going to take a look at how ADTs are used. We're going to move into how you can use ADTs or how receivers can use ADTs. We're going to talk about delivery preferences in MyHin today. Might plug in a little bit of future-looking things, but focusing on what's available today. We're going to talk about Z segments. And if you don't know what a Z segment is, you're like, wow, that means nothing to me. Z segment is something that is appended at the end of an ADT, and we'll get into that more. And then we'll talk about where we're going with that. So let's get right into it. Oh, I need to click on the screen so when I click over, I'm moving the slides. All right. So here's our refresher. ADT stands for Admission Discharge Transfer Notification. It is an HL7 standard. It does communicate information historically associated with a person having an event in a hospital setting, but really it can be a notification that a patient is having an encounter anywhere in healthcare or anywhere in general. Almost all, definitely all certified EHR technology is going to be competent at generating ADTs. So let's talk about some of the major HL7 standards. And I break this down into 3 groups. I went to HL7's site and they did not break it down this way, but I really think this makes the most sense. When you're talking about messages, you've got a whole group of things, and people will have different versions that their EHRs or electronic health records support. You may be on version 2.3.1, 2.5.1, 2.7, 2.8. The versions keep incrementing higher, but it won't go above 2. something because they already have version 3 reserved for their reference implementation model of CDA or clinical document architecture. So the reason this makes a difference is that an HL7 message is intended to be an alert. It's not going to have a whole story that's telling you everything you need to know from start to finish with the patient. It's what's happening right now. A document is more of a historical artifact that's looking at what happened when and how did things end with this encounter. Documents are, HL7 documents, I should say, are all composed in XML format, whereas all of the HL7 messages are pipe delimited, which is that symbol there I have. It's very similar to the concept of a comma delimited file or a CSV that you might be familiar with, but it's just using a different character to separate fields. This means that for messages, you can think of it kind of like a spreadsheet, except for every row is telling you unique information instead of there being columns that give you a point of reference. Whereas a document is structured much more in a encapsulated pieces of data format. And finally, this third category that came out in 2013 is FHIR, or Fast Healthcare Interoperability Resources. And FHIR, it kind of merges the idea of a data payload with the way that payload is exchanged, because FHIR is based in REST APIs, whereas a document or a message can really be exchanged any way you can exchange any file. You can use SFTP, you could use MLLP over VPN, which is minimum lower layer protocol over virtual private network. You can exchange it over direct secure messaging. There's all different types of ways. And FHIR, technically, you can communicate packaged FHIR things through other mechanisms, but FHIR kind of has that transport already built into it. So let's take a look at an actual ADT. If you've never seen one before, this is what an ADT looks like. Obviously, this is not going to have any real patient information in it. But let's try to take a look and see if we can parse some critical information out of it. You can see at the beginning of each line, there's a 3-letter header for each what's called a segment. If we take a look at these, this tells us the type of information you're going to find in each row. So MSH stands for message header, and that's generally going to be metadata to let people know things about the message itself. When was the message generated? What system was it generated out of? Is this a production message or a test message? It'll have an identifier for this specific message. But it's all just so that you can know what is going to be in the message without getting to any PHI. Then the event segment is going to tell you specifically what this event is. It's going to tell you this is an admission event. Then you've got the patient identification segment. That's pretty self-explanatory. It's telling you who the patient is that this message is about. Then you're going to learn things about the visit, what observations have been made, what diagnoses have been made, if the patient has insurance. These are all defined by those different message segments. So now that we know, when we look at that PID, patient identifier segment, we know that that information is all going to be about the patient. We still need to know how to parse the information within that. As I mentioned, an ADT is pipe delimited. And so you can see I have highlighted here all of the pipes. And so you can imagine if this were opened in something like Excel or a spreadsheet, every time you see a pipe, that's a new cell. And within each cell is one specific data element. That one specific data element that I'm now putting in quotation marks may be subdivided into different pieces. So you can see where on the first line, I'll see if I can do it with my mouse. I don't know if you can see my mouse. I hope you can. Right here,
your mouse.
Great. It says MyHin, and then there's a caret, and then 1.1.1.1481. So this is telling us whom the message is going to, and the first part before the caret is a human readable name, MyHin, and then after the caret, it's an identifier to identify MyHin. So that caret is a subdivider within a field, but the overall field is still saying who's the receiving entity. So now that we understand the beginning of each segment identifies what information is going to be in that segment, we kind of understand how the pipes work. Let's take a look at this tool. Oh, I made that go a little too high, but that's okay. Let's take a look at this tool that we actually had an intern make like 8 years ago, but I always come back to this. We call this the MyHin Easy ADT. This color key is probably not up to date, and I apologize for that. It was up to date as of 8 years ago, but the green, yellow, blue, red, the color key is at the bottom right. That may not be accurate. I would not use this as your implementation guide reference right now, but it does break down what information should be in each spot within the segment. So if we take a look up here at the message header, the MSH, you can see the first thing it does is identify sub-delimiters. So it's telling us a caret is a sub-delimiter, and if we have to delimit a field within that, we'll use a tilde and then a backslash and then an ampersand. So anywhere that you'd have to get to some super granular type of data within a field, that's how you would separate those fields. From there, it's going to tell us who the sending application is, the sending facility, right? The same data that I said was going to be in the message header, but you can use this kind of as a key to look, and I cut the MSH off here. So let's go straight to the patient identifier segment. So you can see where it says Jones, caret, Aiden. That's going to be the patient name, which I apologize that I think I need to update this easy ADT, but let's go to the 1137. We can see 1137 is the patient ID spot. So we can kind of use this as a map to understand the information that's going to be contained in here. And so what I really want you to walk away from, not necessarily that you can decode an entire ADT, but that the message between, or the information between the pipes is not necessarily always in a, like developer code scenario. You have to know what field to look in, but you can oftentimes find that field that you're looking for. And it is data that a human could get some information from without being an expert on, say, ICD-10 codes and things like that. There are going to be ICD-10 codes, but you can see here under the diagnosis segment, it gives a code 21273008 and then a human readable name after that. And then it said, this is actually in SNOMED, not in ICD, but it's telling you the system that code is from as well. So that gives us kind of a point of reference of how we can interpret an ADT, and that's really true for any HL7 message. Different HL7 messages and even different ADT message types are going to have different segments. The ones that I showed you are not an entire comprehensive list of every segment that could be sent, but those are the most common segments you'll find in almost every ADT. Do clinicians need to be able to look at the pipe delimited ADT and make all those interpretations? Probably not. There are circumstances where it could be helpful, but it's probably not something that's worth dedicating their time to understand. There are a lot of different tools, there's a lot of vendors, there's a lot of approaches that you can use to ingest ADTs into your own system, or there are visualization tools that will allow you to see the data that was in the ADT without being able to interpret the ADT directly yourself. Electronic health record vendors oftentimes are going to have an ability to receive ADTs. It may not be everything that you've ever wanted, but it probably does do a pretty good job of at least knowing what data is where and being able to put that somewhere for a person to read. Care management platforms usually have a more customized approach, trying to tailor to their customers. So at least the customers that I've worked with in the past, the ones that were ingesting ADTs into a care management platform outside of their EHR typically had a more positive outlook on the ADT data they were receiving. Health information exchanges may offer tools. MyHIN is no exception here. We do have a transitions of care viewer inside of our MyGateway platform. MyGateway is the site that you can log into through a web browser that MyHIN offers, and Transitions of Care Viewer is one of the tools within that that site that you can get to. The Transitions of Care Viewer is not what we're going to go into today, but know that it is available. It's not designed to be the most customized. It's not intended to be the highest end ADT process you can possibly come up with, but it is designed so that you can understand the information that was in an encounter for your patients. Some direct secure messaging platforms do have visualizations. Sometimes it's only for the documents. Remember when I was talking about messages versus documents? A lot of direct secure messaging platforms have a document viewer, but not a message viewer. Some do have message viewers, and that is something to pay attention to when you're looking at different direct secure messaging options. There's also third-party software vendors that have ADT platforms that can ingest the data, that can present the data, that can put the data into custom workflows as well. We have been getting a lot of questions about the direct trust event notification standard. I think I personally have fielded maybe at least one a month for the past year, maybe 2 years. So I didn't want to talk about ADTs and not talk about the direct trust event notification standard. What you need to know about the direct trust event notification standard is that, first of all, when we're talking about event notifications, they are referring to HL7 messages and almost exclusively ADTs. So when we're talking about that standard, we're talking about ADTs. Real quick, just as a point of reference, I want you to know that direct secure messaging as a standard, maybe not however it's implemented in every case, but as a standard, direct secure messaging works just like email. You have a from, you have a to, there's a subject line, you can put text in a body of the message, and you can attach whatever you want. You can send to anyone else who has a direct secure messaging account. Typically, it has to be accredited through Direct Trust, which is the governing body over direct secure messaging. You can set up custom connections that aren't accredited, but typically for most message flow, you'll need to be sending to an accredited address. But other than that, it will function just like email does. I want you to understand that, because however it is implemented for any given EHR or any given other platform, they may have made business decisions for how it will be used, especially to simplify to people who don't want to understand every health technology standard. So the direct trust event notification standard is how to send ADTs over direct secure messaging. And they're saying this is a best practice for how to do that. Now, there's nothing stopping anyone from sending anything over direct secure messaging, and MyHIN is no exception in that, and I'll get to that in the next slide. In the direct trust standard, every message would have 3 major parts. You'd get the raw ADT that would look just like the pipe delimited stuff that we looked at earlier. Then we would have a human readable version that's going to tell you a field name and then what the content was for that specific field. And it's probably not going to cover every field in that message. You probably don't even care what the transaction ID was, for example. It's going to pull out the most relevant clinical information and make that human readable. And the third piece is metadata about the ADT. That metadata is what makes this standard the most interoperable, but it also is the most, nobody was doing this before the standard came out. This metadata that was defined by Direct Trust was not something that people were already doing. That metadata is information that allows you to do some basic decisions, so that when an EHR, for example, gets an ADT through direct secure messaging, it can look at the metadata and know it's received an ADT without having to open the ADT and interpret that. With that being said, this standard was just released in 2020, and it just received ANSI approval in 2022. MyHIN does not currently have all the pieces of the direct trust standard. We recognize this is an important standard to adopt, and it's on our roadmap. We are moving to adopt this standard, but here's what's available today if you want to receive ADTs from us through direct secure messaging. We have the raw ADT, and that can be delivered no problem. We also have a human readable version of the ADT that can be delivered through direct secure messaging. However, it's not attached to the message. It is in the body of the message. So in that respect, we're not compliant with the direct trust standard, but we can get you a human readable if that's what you're after. the metadata is the biggest piece that we still have on our roadmap to build. The human readable, putting that in attachment is not going to be the biggest lift we've ever done, but the metadata is development work that we have on our roadmap planned. All right, so I've been talking for quite a while without asking for questions. I guess it's time I should check. I don't see anything in the chat that anyone is asking, but let's see if there are questions before I move on.
There was one that ended up in the Q&A, not the chat. I'm sorry, there's kind of two different ways that people can submit questions in this webinar feature. So Amy Bailey had a question. Let me post it into the chat because it is a little long.
And she had to leave early, but I don't know if she was making a point or if she had a question. So Mike, let us catch you up. Sorry, because you're like, you're doing the thing. So basically, she says that she finds that many patients and some providers are unaware that their DNR code status in the hospital ends at discharge. This may have been covered in the last meeting, but is it possible to offer this information on the after visit summary? Apparently, that's the terminology they use in Epic that is shared with the patient and the PCP. Is this something that you are prepared to answer right now, Mike? If not, we will make sure to follow up.
I think it's something that should require follow-up.
Thank you.
I can partially answer, but I think for a more comprehensive answer, we should follow up. There are patient information update ADTs that can be sent after discharge. So if we go back to the message types, there was an A08 and an A31 are both patient updates. The A08 is an update while the patient is still in the hospital, and an A31 is an update after the patient has been discharged. So there is a message type for that. As far as the do not resuscitate information, that is something that I don't have. I'm not equipped to answer today.
Fine. Mike, are you speaking?
Good thing you asked. I was just reading the header of the slide. I hadn't gotten into content, but I'm glad I didn't get very far. So, innovative uses for ADTs. What I'd like to do is I'm going to talk about things on this slide that I'm familiar with, but at the end, or if anybody in the meantime wants to type these things up in the chat so that you've got ample time, I'd really like to hear from others how they are using ADTs that may be innovative or different from the scenarios that I've got here. And these are obviously bullet pointed, very summarized versions. I'm going to talk through them right now. So let's start. But I would like to just understand more how other people are using ADTs that I might not be familiar with. But number one use for ADTs is knowing where a patient has been. Because an ADT can be generated in an inpatient or outpatient setting, people who are receiving ADTs can know, oh, I'm not the only primary care physician or family doctor or whatever that this patient goes and sees. Or you might know that, I guess, maybe they went to a skilled nursing facility and now they're in the hospital and or the other way around. There's all different types of scenarios where knowing that a patient is in another care setting is very valuable, and getting it through ADTs both provides a close to real-time way to get that information, and also you don't have to go looking for it. It's something that can be pushed to you. Care coordination from an inpatient to an outpatient setting. This I kind of got into in the last week's This is the happy path where somebody gets admitted to the hospital and the primary care office will schedule a follow-up visit after they're discharged where they can make sure they transition smoothly out of the hospital back into regular life and back to having a relationship with their primary care provider. We can address hospital utilization as a primary care. This can come from both the healthcare provider or from the payer perspective. They have care managers who are monitoring ADTs for their patients. And if somebody is consistently going to the emergency room for things that could be dealt with in primary care, but they don't go to their primary care office, that may be something that just having a conversation with the patient could save a huge portion of healthcare finances. Creating patient registry from a live feed with certain criteria. This is probably the one that needs the most explanation because that word doesn't help a lot. So you may have a very large patient population and you're getting a ton of ADTs. And when you're getting ADTs for your patients, you could say, if we get an ADT for one of these high-risk patients, and if it was an inpatient encounter and it meets this other criteria, put it in this list of patients that meet this criteria so we can watch this population of patients. Obviously, that was one very specific scenario. You don't have to pick patients you already know are high risk. You could be looking for other criteria to determine if they are high risk. But the idea is you can use criteria from those fields in the ADT to narrow who you want to look at and have kind of a patient registry of those things at that point. There's population disease or condition monitoring. This is something very similar to what the public health reporting use cases are that are going to the Michigan Disease Surveillance and the syndromic, that's the word I'm looking for, Michigan Syndromic Surveillance System. There was actually a proposed use case a long time ago that we could be monitoring ADT feeds and automatically, if there's a certain condition code, send that to the Michigan Disease Surveillance System. I think we've moved beyond that, but that's kind of the idea, is that you can identify ADTs based on specific diagnosis code sets and say, now that we've got these ADTs coming from our hospital setting, we know this section of my patient population has this condition. Risk stratification, definitely, even just what I was saying earlier, by identifying patients that are using the hospital as their primary care setting, that's a risk in and of itself. But obviously there are risk of readmissions, there are risks of big events that happen, and you can use ADTs to predict people who are high risk. This is one that I was just trying to think from my lens, because I'm also over our social determinants of health technical work, that you can use it. There are frequently social diagnosis codes or Z codes included in ADTs. That's not a mandatory thing that anyone has to do. So you can't expect that every time there's a social need, there will be a Z code, but there may be Z codes included in diagnoses inside of ADTs. Readmission monitoring. If a patient was, a great example is, I'm going to combine readmission monitoring and the next one, real-time active care relationships, and tell a story about how we're working with a number of hospitals in this avenue. So when a patient is admitted to a hospital and MyHIN gets that ADT, we can create a relationship between that hospital and that patient So now we know that that hospital is going to care about that patient. So if they get readmitted to another hospital, that ADT can get notified and they can see like, oh, was it being readmitted for a cause related to their visit with us? And you can look for that kind of readmission information and try to improve and prevent those readmissions from occurring. The learning health system is a concept that has been around for a while. Dr. Charles Friedman from University of Michigan was whom I had first heard present on the idea. I think that University of Michigan now has a learning health sciences department. I may be wrong in that, I apologize. But the idea of the learning health system is that the healthcare system itself will change its processes and improve its processes based on getting information as close to real time as possible. One way it does that is by looking for trends in data that are coming through in high volume feeds, because just like AI, you need to have a very large data set to train AI. The larger data set you have, and the ADT feeds that we have in Michigan are very large, you can start to look for trends in a population. Just like I was talking about with the registry or with the looking for certain conditions, you can look for, or with the state of Michigan looking for doing disease monitoring. The learning health system idea, when I had heard Dr. Friedman present on the learning health system, the example he used was Google was able to pretty successfully for a long time predict flu outbreaks before public health monitoring systems were able to, based on people searching their symptoms in Google. And they just go online and say, does this mean I have the flu? And Google would see, oh my gosh, there's a huge surge of people searching with these symptoms in this very specific region. We think there's probably a flu outbreak happening right there. And Google has since stopped that at least publicly announcing that. But for a while there, they were able to monitor that type of data. And that's what the Michigan Disease Surveillance System is trying to do today when you're submitting data to them. The learning health system concept is very similar to that, but not limited to outbreaks. An opportunity to send additional relevant information. Okay. So this is where MyHIN starts to be able to have some value add. Because an ADT came into MyHIN and we know that an event has happened with this patient, and because we have this active care relationship service that knows who cares about this patient, we can, at the same time that we're passing that message, we can say, this patient was discharged from this hospital, and just so you know, here's some additional information we know about the patient that may be relevant. This is an opportunity. There are, I'm going to talk about Z segments in just a minute, but that's where the Z segments start to come in, is what information can we add? We're not going to change any information in the ADT, but what other information might be relevant to tell at the time of an admit, a discharge, a transfer, or any of those event states. Let's talk about MyHIN delivery preferences before we get into Z segments. So this is the same scenario that I walked through last time. This is just showing that a patient gets admitted to the hospital. Once MyHIN receives it, I want to hyper zoom in right now on the ACRS, Active Care Relationship Service, or ACRS, and health directory there, because we're going to talk about delivery preferences that are stored in the health directory. So I already talked a little bit about the Active Care Relationship Service today. That's a list of an organization or a provider and the patients that they have relationships with. An active care relationship is defined by the fact that either you have a contractual relationship with the patient, or you have a treatment relationship with that patient and expect to see them again. But either way, once we know that you care about this patient that we got a notification for, we go to our health directory and we're going to look up, okay, do they want, this is a patient they care about. Is this an event that they care about? And if so, where do they want it delivered? And that distinction I didn't really get into last week. So let's talk about the two primary delivery preference options that are available today. Number one is, how do you want to get the message? And the most common three that are out there today is direct secure messaging. And as I mentioned earlier, you can get the raw ADT or a human readable version of that. There's the minimum lower layer protocol over virtual private network. And then you can also see those ADTs through our transitions of care viewer. MyHIN likes the idea of being transport agnostic, and if there's an emerging standard for how these are, how ADTs could be exchanged, we're trying to stay atop of that. So things like the direct trust event notification standard, but if there's entirely new exchange protocol, we'll also want to support those over time if that's what stakeholders are asking for. The second option is, what message types do you want to subscribe to? This was a not originally part of our service. We added it later because what we found is there are certain message types that add a lot of volume of messages and not necessarily a lot of value. So I have on the right here, obviously this is not all of the message types. I only did AO1 through AO8, and then I showed A31s because those are the after discharge messages, updates for comparison. And you can see that the AO8 here is far and away not even close to as many people subscribe to it as all the other message types. And why is that? Because the AO8 patient information update this is not a statistic fact, this is an experiential fact, but I would weight AO8 accounting for about 75% of message volume. But it's a lot of time going to be updates like when the patient got here, they were unconscious, so we didn't have their address and things like that. So they're updating the message with an address, or we now know what the insurance information is, and we didn't before. They'll be sending those types of updates through an AO8 that aren't necessarily the triggering events that people are looking for to take action. Now we're going to get into Z segments. All right. So a Z segment, HL7 uses the letter Z for a lot of their non-standard things. So there's Z segments, there's Z messages, there's Z all kinds of things. You heard me talk about Z codes earlier. They're basically just extensions to whatever the standard is. This allows us to the opportunity that I was talking about on the previous slide. A Z segment allows us to invent our own segment, and we define what data is going to go in there, and we can plug data in without changing any of the content inside of the ADT. If you're defining your own Z segment, it's a best practice to always start that Z segment with the letter Z, so any receiving system knows this is not a standard segment, it is a custom segment. All Z segments should be well defined between trading partners. You should not be getting Z segments and not having any idea what it means. I mean, generally, that's probably a good idea in any case of exchanging clinical data. If you're getting clinical data and you don't know what it means, that's probably not a great thing. But definitely, we're not promoting or excited about the idea of passing one-off Z segments that aren't defined anywhere. So we try to document the Z segments that we're going to create. Not try, we do document the Z segments that MyHIN's going to send. These are the Z segments that are that we are appending to ADTs today. So the first one is the provider whom we matched on in our active care relationship service. So we got an ADT in for patient Michael Taylor, and we said, who cares about patient Michael Taylor? And we said, I know Dr. Joanne cares about Michael Taylor. And so then when we send the ADT to Joanne, her organization might be very large. There might be lots of providers that have a lot of patients. So we append in a Z segment, this is Joanne's patient, basically. That's what we're communicating there is, this is who we matched on in ACRES that had a relationship with this patient. The next thing is the common key segment. This segment is typically only included if the receiver participates in the common key service use case, but it will have our common key appended to the message for that patient. If you're unfamiliar with our common key service, it is essentially a medical record number, an MRN, but it is not from any one health system or anything like that. It's exactly what it's supposed to sound like, a common key that can unlock patient matching across different health systems. It is intentionally very long. This example does not have as many characters as a real common key because it was intentionally made long because we're intentionally not trying to make a new patient identifier. The common key is not going to be appearing on someone's, ID anytime soon. It's intended for system-to-system patient identification.
Sorry, Mike, I just want to give you a time check. It's 12:51.
Oh,
We're here until 1, and we have lots of, yes, we are going to give you these slides. Yes, we will give you the recording, but I didn't want you to like squeeze, let's get to the juice. But I think that we're there. So if you want to spend 2 more minutes on Z segments, so be it. But we could also, we could do some polling. You can ask your very good questions now so that other people can learn. Please return learning to our system. If you are part of our network, which we really want you to be, we'd like to also learn from you and then pass that learning on to our other participants. Does anybody have any specific questions at this point? Please, we've got Mike here for it's very hard to get him. We have him for 8 more minutes. There was some stuff going on in the chat, which I feel like I handled. Mike Taylor, we were talking about getting some of our technical operation incident emails. Gosh, there was a couple of really good examples of how ADTs are used in psychiatric situations and moved to care, a care manager or a therapist. Also for population health, of course, the payer community in Michigan is very involved with MyHIN, and I know that they find value in receiving these ADTs in real time. What else? Is anybody else using their ADTs for crazy good outcomes? And you don't have to be too specific because I know that, yes, that there are competitors here, but certainly we all want, human beings to live. So tell us what's good. Anything else in the chat, guys, that you're seeing, or any questions or comments? Okay.
I did think of one other example of how ADTs could be used that wasn't on that list. And I don't have a ton of context on this one, but I remember someone telling the story of they had a patient that didn't show up for a scheduled visit, and they pulled up the patient's chart, and in their particular workflow, there was a tab in their system for seeing encounter notifications, and they clicked on it and saw that the patient was in the hospital right now, and they had been admitted last night for some event. So instead of leaving a message on that person's phone, saying hey, we had a meeting scheduled, we had an appointment scheduled, they were able to contact the hospital and actually address the patient there.
Harvey has been asking this question a number of different ways, Mike Taylor. He's asking if when a patient has an appointment scheduled, at a hospital, is that information being shared in an ADT? I bet we could say sometimes. Oh, you are muted. I heard that it can go in an A08.
I think it could. I don't have information about whether it is or not.
Is anybody here sending or creating an ADT when a patient has scheduled an appointment? That's not really an encounter. I mean, it's something that happens, but it's not an encounter. So Harvey, I don't think we have good examples of using an ADT to let other people know a patient has scheduled an appointment. I know of other ways that we could get that information to care teams, but I'm not convinced that it's through an ADT. Thank you. I'm talking to you in like a day anyway, Harvey. 1256. So this was Bits and Bytes. I really hope it was useful, and I hope that I hope that you could see the difference between the download and the Bits and Bytes. Our plan is to go, some centers will send registration AO4s for future visits, as Hannah, who works at MyHin. She's a genius. We can look into that, Harvey, AO4s. Anyway, Bits and Bytes, the download. We're going to go use case by use case. Does anybody feel strongly about which use case we should go to next? I was thinking we could talk about public health. I was thinking we could talk about immunizations. We could delve into CCDAs, which is very, very scary. Suggestions for the next download in Bits and Bytes? Manzi Barol is asking, are ADTs commit only, or can they be edited after being sent when some information can be corrected in the past ADTs? Yes. So isn't that what you were saying? You were like, look, when people update their ADTs, which happens a lot, that information can be sent, but opting into all of the times when people have to go back to update it can be, it can really mess up a workflow, I suppose. I believe we have a tool that updates it for you when you go to view the information about the patient, but having it, having those things come through all the time.
Yeah, there's two different mindsets about a patient encounter. There's what do we know right now? And that's what ADTs are intended to do. And so if you want to edit what had been sent previously, it's a new notification. It's that patient information update, whether it was while they're still in the hospital or after. But that is how you'd edit. The way you'd think about editing a document that is more like a living, breathing document would be an HL7 document. And the way I think about it is a document would take every single ADT from one encounter and put them all together, and it would know the patient was admitted at this time, and it was, but if you had updated the patient's address, that's not necessarily an event. That's something that in that document will be updated one time, and it will say this was the right patient address. And it may not even still know what the old address was because it was incorrect.
I hope that helps. If it doesn't help, Manzi, write me. I'm here for you. I'm putting in my thing. Mike, will you advance the slides to encourage dynamic discussion, for which we have, 1 more minute. But look, what is valuable health information to you? What is the most critical things you need to know to make your next best decision? Are you getting that information? Who are you getting it from? How much of it do you think you're getting? Can you share some with others? And are you working with Mayan?